Welcome to St. Joe's Healthcare Hamilton Medical Grand Rounds. Get you to advance to the next slide and to slide 3. So we'll start off by acknowledging the land on which we stand and from which we log on this morning. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. So we're welcoming our speaker this morning. This is his conflict of interest slide. And as you'll see, the consulting fees are relevant to the topic. Next slide. So we have this morning Dr. Jason Cheung, who is an associate professor and in fact our head of service for general internal medicine at St. Joseph Healthcare Hamilton. He's presenting on the topic Oskee Wee Wee, Oskee Wah Wah, lesson learned from a team internist. And because we usually have the head of service introduce our speakers, and we want to give Jason the same treatment without having to introduce himself, I've invited John Neary to co-host with you this morning, and he'll provide a bit of a more rich intro.
Thanks, Madeline. So as Madeline said, we're very privileged to have Dr. Cheung speaking today. He's Associate Professor of Medicine with the Division of GIM in the Department of Medicine at McMaster. He completed his medical training at McMaster from clerkship or pre-clerkship all the way through his fellowship in GIM. Along the way, he had he had a pre-clerkship clinical skills tutor of very dubious quality. He sent him off on the wrong, but that was me. He joined the department in 2014 as a clinical scholar, completed a Master's of Health Management through the DeGroote School of Business. He's had a lot of leadership roles. He was the CTU director at St. Joe's from 2016 through 2020. Recently took on the role of head of service of GIM. At a very difficult time. I don't think he had any spare time, but he tells me that in his spare time, he enjoys the outdoors, fishing, and spending time with his wife and his 1-year-old daughter, Emma. I'd like to put in a plug. I hope this year, in his role as TICAT's team internist, he can teach the special teams unit the difference between a touchback and a rouge. Dr. Cheung.
Thanks so much, Sean. I appreciate the intro. Thanks so much, Madeline, as well. I'm very grateful for being able to talk to you guys about this topic that's near and dear to me for the last several years. It's a little bit different from our usual Grand Round topics, so I hope you guys will learn a little something. It's basically a collection of cases that I've come across over the last several seasons that I've spent as the team internist with the Hamilton Ticats. So I want to start off with giving you a bit of an intro as to how I got involved in this. Many of you are probably wondering, why does a professional sports team actually even need a general internist? But back in, I think it was around 2017 or 2016, the former medical director of the Hamilton Ticats stepped down from his role and retired. I believe it was Dr. Levy at the time, and he had been a long-standing member of their organization. And they had hired Dr. Femi Ayeni, who is currently the orthopedics division director, to be their new medical director. And in his efforts to revamp the medical team, he wanted to create a team that was all-encompassing. So he brought on several physiatrists to join his team, another orthopedic surgeon, a diagnostic radiologist who was dedicated to the team, an emerge doc, and finally myself, an internist. And I remember quite vividly driving home after rounding at the Juravinsky. I was on the link, driving back, and I got a call to my cell phone from paging saying that somebody wanted to speak to me. So on came Dr. Ayeni, and he said, "Hey, I've never met you before." And I acknowledged I'd never met him before. I'd heard the name, and he said, "Do you want to come and join the Hamilton Ticats? I'm putting together a medical team." And I thought to myself, well, I do like Hamilton. I've been here since around 2007, I think. Ticats are, the heart and soul of this city, so why not? So in 2017, I spent my first season working as the team internist, and I've been doing it ever since. We had obviously an unfortunate year break, year before this past season during the COVID pandemic, but it's been quite the ride since. So when I first joined the team, again, I thought to myself, why do you guys need an internist? And over the last 4 seasons, these are the sort of things I've seen. I've seen players, I've seen coaches, I've seen team personnel, as well as family of the aforementioned individuals. And the types of conditions are very similar to what we see on a day-to-day basis in internal medicine. I've seen a whole slew of abnormal ECGs, had a gentleman with rhabdomyolysis, ulcerative colitis, diabetes, asthma, non-ischemic cardiomyopathy, and more. And so really, there's been a whole array of different conditions that I've come across in looking after some of the members of this organization. For today's talk, I wanted to take you through three different subjects related to my experiences with the team. So I've divided into 3 chapters titled the heart, the muscle, and the lungs. And the first segment is to develop an approach on cardiac screening in athletes. The second is to review exertional rhabdomyolysis and return to activity protocols. And finally, I want to discuss return to play after COVID-19 infections. So the first chapter, titled the heart. So this is sort of what we see as internists on a day-to-day basis. 56-year-old gentleman with diabetes, hypertension, dyslipidemia coming in with chest pain. You can see here on this ECG, there are a number of abnormalities, infralateral ST segment depressions, T-wave inversions, very much in keeping with an STEMI or unstable angina. This is an ECG that I have typically seen on the team. So this was actually part of one of 3 referrals that I received, 3 ECGs that I'll be reviewing today, basically during the first week with the team. So this ECG here shows sinus bradycardia, incomplete right bundle branch block, and LVH by precordial voltage criteria. Now it's basically asked to evaluate this gentleman. The second ECG may look a little bit more worrisome to you. Normal sinus rhythm, LVH, and you can see these very profound T-wave inversions throughout the precordial leads from V1 through V6. And this is a gentleman with right bundle branch block, but otherwise normal sinus and no other abnormalities. So cardiac screening in athletics has a deep-rooted history, particularly in the United States. It's been happening for more than 50 years, and it happens anywhere from the high school level through to the collegiate level and up through professional sports. And really the ultimate goal behind pre-participation screening is to prevent sudden cardiac death. It can be a really devastating event when this occurs. And in terms of sports in which this tends to occur, in the US, it usually is in football and basketball, because these are sports that have the highest degree of participation and they have the highest degree of intensity. And over in Europe, as you can imagine, soccer tends to be the one most associated with these events. Having said that, sudden death in sports is actually extremely rare. Motor vehicle accidents in the States is a leading cause of death amongst young individuals, and it actually represents a 2,500-fold higher frequency than sudden cardiac death in athletics. In fact, in the US, it's comparable to lightning strike fatalities, so it's really not that common. In a US registry that was tracking the number of deaths in sports, there were about 2,500 deaths over a 33-year period, which amounts to about 75 in any given year. But ultimately, even though this is an extremely rare event, it's really something that can be quite shocking. It's a tragic event, and it really leads to shockwaves across communities and sometimes across an entire country. So for that reason, cardiac screening has really played a big role in professional sports. The causes of death when it comes to sudden cardiac death in sports usually are comprised of either HOCM, which makes up about a third of these cases, as well as congenital coronary anomalies. There are a number of other cardiac conditions that can result in cardiac death, but they usually make up less than 5% on an individual basis. And then more rare conditions such as Wolff-Parkinson-White or ion channelopathies can also result in death as well. This is a study that was done in Minneapolis, looking at about 1,400 athletes and unfortunate demise. And this was basically the breakdown of the underlying causes. Again, you can see here that HOCM comprises about a third of cases, and the other major contributor is coronary artery anomalies. In terms of cardiac screening, the American Heart Association first came out with its guidelines back in the mid-90s. And they felt that a 12-point history and physical examination was a good screening tool to use. And if an individual had a positive screen for any one of these 12 points, they should go on to have further investigations with more expert opinion. So some of the components of this history and physical examination are fairly intuitive, asking about exertional symptoms like chest pain or syncope, identifying whether they've had a previous murmur, as well as prior history of hypertension. But the family history is also an extremely important emphasis, and that if anyone has a family history of premature death that's sudden and unexpected, then that would also be a positive screen. Finally, in terms of the physical examination, looking at the precordial exam as well as vitals is really the emphasis here. And on exam, really looking for a murmur that's in keeping with HOCM would be a positive finding that would require further investigations. Fast forward about 10 years later, the European Society of Cardiology came out with its own set of guidelines, and they again re-emphasized the importance of a thorough history and physical examination, but they added the 12-lead ECG as a standard screening tool. And this has always been a point of controversy, and I'll go on to tell you why in the next slide. Subsequently, the American Heart Association 2 years later came out with its own revised set of recommendations, and they just added on 2 additional questions to their questionnaire from previous, and included prior restriction from participation in sports, as well as prior testing for the heart that was ordered by a physician, as 2 additional points that if you had a positive finding, you would require further testing. They actually went on to emphasize that a routine screening ECG was something that should not be done unless, of course, there was a positive screen on the questionnaire. The reason for this is that ECG interpretation among young athletes is extremely different from the day-to-day that we work in. So this can be fraught with inaccurate interpretations. There's a high degree of false positive rates, and this would unfortunately result in unnecessary and expensive follow-up testing. It can also result in unnecessary restriction from sport, which I'll talk to you guys about later, as well as provide some false reassurance if you do have a completely normal ECG but an abnormal finding on physical examination. Thankfully, a couple of years later, the CCS actually released its own joint statement on cardiac screening in athletes. And this is a much more pragmatic approach to how to screen athletes. They had a tiered approach to this and had 5 main recommendations. The first one was to, again, perform a history and physical examination based on the American Heart Association guidelines. He said they recommended against the routine use of a 12-lead ECG, but did strongly recommend that you do proceed with a 12-lead ECG if you have a positive screen based on your questionnaire or physical examination. In terms of ECG interpretation, this is why there are some challenges when it comes to looking at ECGs of young athletes. There are a number of different findings that can be completely normal, and there are a number that can be extremely abnormal. And this was a consensus that was developed at a summit in 2015 in Washington that looked at how to standardize the interpretation of ECGs among athletes and to help help physicians further risk stratify who needs further testing or not. So people in this green box here with these findings don't need any additional testing. People in the borderline yellow box here would need further testing if they had positive family history. And people in this red box here have to proceed with further testing regardless of their history. So going back to the 3 ECGs that I reviewed earlier, this individual was sinus bradycardia, incomplete right bundle branch block, and LVH based on precordial criteria. I actually went on to perform further investigations because a lot of these guidelines, as well as that previous, particularly that ECG interpretation guideline, was not out at the time. So I went on to order another test. I went on to order an echocardiogram just in case. But as you can see here, based on these criteria, this LVH and incomplete right bundle branch block is completely normal, and really no further testing is required. So he was actually cleared to play, but he did have an echo that ultimately we can say was deemed to be unnecessary. This second gentleman had normal sinus rhythm, LVH with precordial voltage criteria, as well as prominent T-wave inversions. These T-wave inversions here go from V1 through to V6, so they're quite diffuse. And although his T-wave inversions fall within the normal findings if they were from V1 through V4 in a Black athlete, which he was, he could typically be cleared. But again, these inversions extended beyond V4 into V5, V6. And so he did actually have a significantly abnormal ECG based on these criteria here. And we went on to do an echocardiogram. Thankfully, his echo was completely normal. And again, he was cleared to play. This final gentleman had the complete right bundle branch block. And again, going back to these criteria, right bundle branch block sort of falls in the middle criteria. So it depends on whether or not they have additional family history or other findings on their ECG. And in this fellow, his father actually passed away at the age of 30 on the track when he was running. And so this was an extremely positive family history. And so he went on to have additional testing. But this was a good example of why standard ECG screening and that triggering further testing can have significant implications. His echocardiogram was relatively normal, but he was extremely anxious. And he went on to have further testing, referral to cardiology, ended up having a MIBI done as well as a cardiac MRI. And ultimately this fellow, even though he had completely normal cardiac testing, was extremely anxious from the original assessment, and he actually ended up withdrawing from the team altogether and retiring from professional football. So, pan screening of all individuals with ECGs, again, can have upsides in terms of ruling out conditions that can result in sudden cardiac death, but at the same time can create a whole slew of anxiety, and this is sort of a good example of that. All right, so moving on to our next chapter, otherwise known as the muscles. So this is what I normally see. In fact, there was a case of this not too long ago that I had under me when I was in medicine. This is of an 84-year-old female found on the bathroom floor by a neighbor. Unknown duration of time on the floor, was last seen about 3 days prior. They were brought into the emergency department. CK was 32,000. They're an AKI. And they had urine that looked like this. So this is your typical case of rhabdomyolysis. This, on the other hand, is what I saw on the team. So this was a 32-year-old running back. He was just signed with the team about a third of the way through the season. He participated in 2 practices, and subsequent to that developed significant chills, generalized body aches and nausea, and was subsequently brought to the emergency department. There he was found to have a CK of 4,200 and his creatinine was 282, so quite worrisome. So this was a case of exertional rhabdomyolysis. It's essentially this fairly similar to rhabdo, except it's triggered by something else. It's basically the breakdown and necrosis of muscle after engaging in strenuous physical activity. Certain risk factors include being unaccustomed to physical exercise, similar to this gentleman who had been playing for some time, inadequate hydration, ambient temperatures, certain medications like statin use, illicit drugs, as well as recent viral illnesses are all particular risk factors for this condition. The symptoms that people typically experience include myalgias, swelling, as well as general weakness, but people can also have more systemic symptoms, including fatigue, nausea, fever, vomiting, and confusion when they're particularly unwell. The diagnosis of this condition doesn't really have a particular criteria, but if you review the literature most papers would go on to describe a criteria that's widely accepted to some extent of a CK elevation of greater than 5 times the upper limit of normal, as well as myoglobinuria that's accompanied by symptoms of myalgia, swelling, and weakness. The treatment of this is very similar to rhabdo. It's really based on IV hydration. You should monitor people's CKs, lights, and creatinine to ensure they're normalizing. But in more severe cases, people can develop ATN, become anuric, requiring a nephrology opinion. And in other more severe cases, they can even develop a compartment syndrome and require decompressing fasciotomies. So in this player that I saw, this dates back a number of years ago. So he had presented to the emergency department on September 9th. And he had a CK, as I mentioned earlier, of about 4,200. He received some IV hydration, and he had a repeat set of blood work that showed that his creatinine had come down, but his CK still remained around the 4,000 range. He was feeling better, so they felt it was reasonable to have him discharged. About a week later, they went on a road trip out west. And prior to the game, a few days prior, they had practice. He subsequently had some lab work done, and that's when I received the call that his CK was still in the 4,000s. I don't have the exact value, but it was elevated, and they were worried as to whether or not he could play. So without really much knowledge in this condition, I quickly had to look through the literature and look through to see whether or not he is somebody that we can go ahead and clear for play. And ultimately, we felt that we should probably be a bit more conservative. So we actually flew him home, and he missed the game. And I saw him a couple days later and had him repeat some lab work. And by then, his creatinine had actually or his CK rather, had come down to 1,200. He was feeling fine, and he's a little bit upset that he wasn't able to play, but ultimately, it was the safest route to take in the situation. The next question was really, how do we get this player back on the field? How do we get him practicing again? Is it safe to do so? And can he start playing and continue on with his career? Well, in looking through the literature, there's really not too much out there on return to play after exertional rhabdo. But I did come across this guideline that was developed by the US military because they tend to see some degree of exertional rhabdo. And it's actually quite a pragmatic set of recommendations here as to how to get someone back on the field or back into activity. So I basically took this and went with it. I ensured that he was well hydrated. I was repeating his CKs regularly, and then we had follow-up assessments. And so this is basically the course as to how, or this is basically what the next steps look like for him. So 2 weeks after the inciting event, his CK had actually come down to 300. So he was resting. He didn't participate in any further practices. And I told him at that time, you know what, go ahead and proceed with some light cardio. Although the CK of 300 isn't within normal range, you have to remember he is a well-built athlete, and he's also Black in ethnicity. And so their baseline CKs are typically a bit higher than their Caucasian counterparts. After performing some light cardio the next day, I told him to do some blood work. He had some more blood work done. And again, it was nominally elevated from previous. So I asked him to, again, do some more workouts, do some heavy weightlifting, and see if he had any symptoms, which he did not. And so we cleared him to play. So 3 days later, it was game day. It would have been a Friday evening. Ideally, the next day I would have rechecked his CK to see where things were at. But again, we're going into a weekend. So I said, you know what, come on back in on Monday and we'll have a look at your CK levels. So on Monday, 4 days after the game, the CK actually popped up to 1,200. And again, this is a little bit worrying, but he was actually completely asymptomatic and feeling fine. Keep in mind that his baseline CK is 300. And again, the widely accepted definition or diagnostic criteria for this condition is to have a CK that's 5 times the upper limit of normal. So he's actually still within that level. And because he was feeling otherwise well, I decided, you know what, why don't we call some experts before restricting him from playing again? And so I gave the neuromuscular clinic over at McMaster a call and spoke to one of the specialists there. And they ultimately felt that based on his history and based on the lack of symptoms that Really, he did not need to be restricted from sport, but they did recommend that he maintain really good hydration. So in collaboration with the team's trainer, as well as the medical director, we decided that we would give this player a liter of fluid before and after every game, and they could do that in their treatment room. And ultimately, he went on to play the rest of the season, including a Grey Cup appearance, and actually did very well without any further symptoms. All right, so my final chapter here, the lung. So this is your typical COVID case that we saw earlier on in this pandemic in particular. These are very typical cases that we've been seeing. 38-year-old, very young, healthy gentleman coming in with the hospital, requiring a few liters of oxygen, found to be COVID positive, and 2 days later ending up in ICU on high flow. Another case, very typical, 64-year-old with fever, cough, malaise for 3 days, coming into hospital on a couple liters, and then unfortunately transferred several days later, requiring mechanical ventilation. People coming in with COVID, as many of you know, can range from symptoms of being asymptomatic or mild, or they can be more moderate or severe. And these are some of the criteria set out by the WHO. What I've yet to see is an athlete coming in with COVID-19. Most, if not all, of the players with the Ticats were vaccinated during the season. That was, I think, one of the requirements. And ultimately, I'd never end up seeing anyone with COVID, but this was always a question that was posed to me: is what do we do if somebody ended up with COVID, and how do we get them back on the field safely? So the clinical time to recovery for mild infections that most of us would have either not experienced, but that many people would have seen in the community, family members or friends, usually they recover after about 2 weeks without any further symptoms. In more severe infections, the median time to recovery is anywhere from 3 to 6 weeks. And after resolution of their acute infection, people can have a whole host of different symptoms, including fatigue, dyspnea, chest pain, and cough. Some people might have persistent anosmia, headache, and dizziness. And anecdotally, I can say that a number of people that I know who have had COVID have complained of postural tachycardia as well. And in more severe or critical cases, people can be left with a lot of psychological and cognitive symptoms. When it comes to trying to get a player back on the field after a COVID infection, really the focus is on pulmonary and cardiac evaluations. Individuals who wish to return to sport afterwards should really undergo a thorough history and physical examination. If they've had more moderate or severe infections, they should undergo a repeat chest imaging with an X-ray just to ensure that any type of infiltrates have resolved. But if there's ongoing symptoms, they should really undergo further testing, including PFTs, and even consider a 6-minute walk test, CPET, or high-resolution CT scan to look for complications. The cardiac evaluation should again take place after resolution of symptoms. But if people are having persistent symptoms, further tests that should be considered include ECGs, cardiobiomarkers, as well as an echocardiogram. And some of these should even be standard for more moderate or severe infections that were experienced. For patients who are experiencing more persistent symptoms of, or experiencing things like palpitations, performing a Holter monitor would be extremely helpful to rule out any arrhythmias. And again, if people are having exertional symptoms, proceeding with exercise stress testing can also be helpful. The concern post-COVID infections when it comes to the heart is really myocarditis. And there are a number of studies that have been done retrospectively, looking at professional athletes or collegiate athletes who have experienced COVID-19 infections to assess whether or not they've had complications of myocarditis. And thankfully, the rates are extremely low. In this study done by Martinez and colleagues of about 800 athletes in Europe, they found that about 5 or less than 1% of them had any changes in cardiac MRI in keeping with myocarditis. And in this larger review of about 3,000 NCAA athletes in the States, found that 0.7% had suspected cardiac injury related to myocarditis. And this was based on ECG, troponin, echo, and cardiac MRI testing. So for mild to moderate infections, patients and athletes should really wait for at least 10 days from the onset of their infection before considering any form of return to play protocol. They should be at least 7 days symptom-free before starting any protocol. And for those with more moderate to severe infections, they really need to wait a much longer period of time before returning to physical activity. In fact, if they've been admitted to hospital, the recommendation is to wait at least 4 to 6 weeks post-discharge before starting any protocols. This here is an infographic that's widely known in the sports medicine community. And it was published in the BMJ and basically describes a staged protocol, 6-stage protocol to return to sport. And again, it emphasizes that patients should be at least 7 days symptom-free before proceeding with any type of protocol. And it's really a graduated set of activity, moving from stage 1 in the red column all the way to the stage 6, which is to return to competition. And so over the course of the 4 seasons, I've learned quite a bit as the internist for the team. And these are just a few things, a few takeaway points. First is to really expect the unexpected, and that athletes can have acute medical issues that are outside the traditional role of sports medicine and internal medicine. We always have to make sure that we can read up and get creative. As you can see, there are certain situations here that aren't really within our comfort zone. There's not necessarily good solid clinical guidelines that we typically see for things like CHF and COPD that we use on a day-to-day basis. So you really have to peruse the literature and see what's out there. And finally, we're never alone. So even though I've been assigned to this role or I've taken on this role, there's always situations that are, again, outside of my comfort zone, and perhaps sometimes asking a friend for an expert opinion can be very helpful. So just in closing, I want to thank everyone for the opportunity to give this talk. And this is my dog, Molly. She's an avid Ticats fan, and this is her during the Grey Cup before last. During the she's cheering on the Ticats. Unfortunately, I think we lost that year too. So thank you very much.
Wonderful presentation. Thank you very much, Jason. And very, very unique set of cases and experiences that you've had in this role that you've had the opportunity to fill. So thanks for bringing us behind the scenes. I'll welcome any questions that folks may have. I see that there are 2 already in the chat, so I'll start there. And we have our first question is, do you encounter sleep apnea? A few years ago, around this time of year pre-Super Bowl, there was quite a flurry of interest prompted by a report of high incidence among football players, especially among linemen.
It's a very interesting question. I didn't come across that. There was, I should say, no, I did come across a case where I did suspect sleep apnea, and it was actually an O lineman who was about 320 pounds. And he had come in to see me with palpitations. And as part of that workup, I did want to complete a sleep study to look into the cause of these palpitations beyond just the straightforward cardiac causes based on its history. Unfortunately, the interesting thing with these athletes is most of them are not Canadian. And even if they are Canadian, they don't necessarily reside here in Hamilton. So their care, unfortunately, is quite fragmented. And I often will arrange a slurry of investigations or sometimes referrals. And many of these players get lost to follow-up. They switch organizations. And unfortunately, there's not much of a sort of centralized way of keeping track of their health records. So it is something that we see. I'm surprised I have not been referred more cases like this. But it's a very interesting point for sure.
Awesome. And with my health policy and administrative hat, it feels like an opportunity for you to advocate to the organization to try to get things a little bit organized. Feel a bit bad for these folks being bounced around from city to city, although I know it's an exciting line of work. So then there was another question regarding ECG for screening and not pursuing voltage evidence of LVH. HOCM is the most common cause of sudden death in athletes. What are the usual ECG findings?
The usual ECG findings are still going to be either you can have ECGs that are normal, but again, findings in keeping with LVH, I believe, are usually the ones that we would typically see. And then there's also the physical exam findings of systolic murmur that worsens with Valsalva or with standing, that have been described in JAMA previously.
Okay, great. Thank you for that. And while we wait to see if we do have some hands up here. We'll get CTU Central to unmute.
You hear us, Madeline?
Sure can.
It's John here. Jason, I'm just wondering, I know this might not have happened with the Ticats per se, but like with sort of all the discussion about long COVID and what that really means as a clinical syndrome and that sort of thing. Do you have a sense of what's been the experience of professional athletes who contract COVID in terms of whether there have been long-term sequelae for their cardiac and respiratory fitness? Like, do they return to their baseline, ability to exercise and that sort of thing, or are a substantial portion somewhat impaired?
Honestly, John, I didn't come across it, and I presented at a recent as part of the Grey Cup festivities. The host team was responsible for giving a talk and discussing with some of our colleagues there. Most people had questions rather than actual experiences as well. So same question was posed to me then, and I have no idea. I would imagine that unless they had severe illness, requiring hospitalization and had, pulmonary complications, I would imagine that most of them would be able to return to sports in a graduated manner, but I'm not sure.
Cool, thanks.
Okay, thank you. We've got a couple of other questions. Next up is Zane.
Hey, Jason, great talk. I think along the same lines, I wondered if you had any experiences with vaccine hesitancy in this population, considering, what's happening in the NBA and Aaron Rodgers, if people were concerned. And the other thing that I think I've heard is particularly athletic people are very worried about the myocarditis risk with some of these vaccines, and then that taking them out of kind of professional capacities in that sense.
Yeah, no, definitely. That was actually from the other team docs. That was actually a question that was posed to me as well around myocarditis is, what do you do with those situations? And ultimately, I mean, we know that the risk is there. They're the population that is at higher risk of developing it if they were to. But ultimately, I think when it comes to risk benefit of getting severe infection versus, having more mild or asymptomatic infections, that vaccines would trump that, because, myocarditis or severe infection could be career ending as well. So I think, ultimately they have to weigh that risk. There was only one case of, it wasn't necessarily vaccine hesitancy, but it was somebody who had an asthma exacerbation that ended up on prednisone for a period of time that only had his first vaccine. And the question that was posed was, when can he have his second vaccine? So there was this sort of WhatsApp group with all the respirologists across Ontario that I posed that question through my wife. And there was not a huge consensus around when they can go back and receive their second vaccine, but we asked them to wait a couple of weeks before getting it. But beyond that, just about everyone on the team seemed to be pretty happy proceeding with the vaccine.
Fantastic, thanks.
Thanks.
Great. Okay, and next we have a question from Ankur.
Hey, Dr. Cheung, cool talk. Thanks so much. Just two quick questions. For the patient who had the, exertional rhabdomyolysis, did the neuromuscular clinic suggest that there was like an underlying metabolic myopathy or like a predisposition to anything?
Yeah, so this was again a good example of fragmented care. So they actually suggested that referral to them just to see them afterwards and do some genetic testing. Part of they did feel that most likely this was just ethnicity related, baseline elevation in CK and the exertion and impact in a football game, especially if somebody like a running back who's getting tackled, that's going to result in some degree of a CK elevation. So they did want to do some testing, I think more on an academic basis and interest rather than anything. But again, this fellow went back down to the States, and then the following year was COVID, so he didn't return, and then he actually retired from sport altogether. But that, it would have been interesting to know whether or not there was an underlying genetic predisposition for him.
I see. Okay, interesting. And then the second question is, do you see a lot of like traumatic VTE in this population?
No, I haven't seen any clots or anything like that over the years. The only trauma that I saw, and again, it was an unusual question to pose to me, and I had no idea what the answer was somebody who had a hematoma in their chest after a impact from a helmet, and he was hoping to fly back to Europe where he resided. And the question was, is it safe for him to fly? So I had no idea. So I called a friend, called one of the thoracic surgeons, and again, he said, as long as there's no pneumothorax, you're good to go. So away he went.
Gotcha, interesting. Thanks.
Yep, no problem.
Okay, great. Thanks very much. I have a question just in follow up to that point about the ranges being different for folks who would identify as Black versus other populations. It's really interesting because what I've noticed over the past year or two has been a questioning of those race-based reference ranges for things. In particular, one of the more high-profile ones has been the correction of the eGFR or creatinine clearance that has historically happened on the reference ranges. And I think when they revisited where those assumptions came from, it appears that that more likely reflected just baseline worse renal health for Black populations, particularly in the United States. And so by being easier or, kind of disregarding, changing the threshold for Black populations, they were actually running the risk of worsening kind of access to care and proper timely access to assessment for renal impairment. So there's been a whole dialogue, which I'm not sure if you've been kind of tuned into, mostly south of the border, because that's where the data came from. And I think when they reflected back as well, the fact that Black, kind of in quotation marks, is a pretty broad category, and to kind of paint everybody with one brush is kind of an issue. So anyway, long rambling question, but I noticed that on two of the instances, there were different reference ranges or different thresholds indicated for Black versus, I guess, other, although you had said Black versus Caucasian. I just wonder if you have a thought on if you've heard anything about those being revisited in light of where the current enhanced awareness of that is, or if you had any more thoughts about those reference ranges. I guess it was in reference to CK and the ECG. Yeah,
no, for sure. I honestly, I wasn't familiar with the creatinine and eGFR update literature on that. It's definitely a point very well taken and something to really take into consideration. I think ultimately, even with the CK elevations, it's not necessarily even, ethnic related comparisons, but even more so just muscle mass itself. We see higher CKs in individuals who are weightlifters or who are more built than others. So perhaps that may be playing a bigger role, particularly among athletes. Having said that, in the outpatient setting for internal medicine, we do get some referrals for elevated CKs quite frequently. And sometimes they're drug related, statin related elevations, but other times it does come down to whether or not it is, when we do assess the patient, we realize there are, they're from an ethnic side of things, that could be a contributing factor as well, because they're otherwise completely asymptomatic. They don't have any muscle symptoms, but I'm not familiar with any updated literature in that regard. Same thing with ECGs as well. It's interesting that there are certain populations or certain changes that are felt to be more related to one ethnicity or another. I don't know if any of the cardiologists on the talk have any comments, but yeah, I'm not familiar with that, unfortunately.
Okay, no, thanks so much. We've got another question. I'm not sure who Cox P is, but they can unmute themselves.
That's Jerry Cox here.
Oh, okay, great. Thanks,
Jerry. Yeah, it's my email address. So the thing you brought up about fragmented care and the lack of follow through on pursuing concerns, and then you mentioned something about players who you're seeing, and there was the pressure to return to play. When can I play? Which I suspect came from the player anyway, and may well have come from management. Then there was your concern that there was lack of a sort of a single record for tracking their healthcare. Have you come across any opposition to people's medical condition being formally identified and recorded? Because from an owner of a sports team's point of view, you don't really want to invest a huge amount of money in somebody who's got a pre-existing condition. And from a player's point of view, if they don't play, they got nothing. So, I mean, a few of the hockey players, the Bulldogs, who have breathing symptoms, have come through our clinic, and all they want to do is to get back on the ice. They're not really interested in inhalers, and inhalers are a sign of weakness and illness. So there's a conflict there. Have you come across that conflict from the player's point of view or from the management ownership point of view?
Yeah, definitely. I mean, even that player that I asked for them to fly back with the exertional rhabdo, management was quite disappointed because he had not even played a game yet. He had practiced, they flew him out west to play, and then he had this elevated CK. So they're actually quite upset with that. But from my end of things, it was the health and safety of this player ultimately, and he ended up in the emerge with AKI. We can't just let him play with this elevated lab value, even though he was feeling well, until he was further investigated. So there was that instance. The other interesting thing with those ECGs that I showed you, there was actually 2 of those players had played in the NFL previously, and only after I completed their assessment and told them everything was normal, they said, "Oh, we already had all this testing done before." I'm like, "What? Why didn't you tell me? Do you not have any records of this?" And I think you're right. There is almost an intentional lack of transparency, or else if things are even seemingly abnormal, there's a reason for ownership and management not to sign a player sometimes. So I think even if we wanted to create, for instance, a league-wide electronic medical record so that everyone knew what was going on, I don't think that players would be open to that, nor do I think owners want to know either. So because then people's value aren't as high on the trading block. So it is a very interesting point, and we do certainly come across that indirectly.
Okay. Thank you very much for that interesting question and discussion. Another question, did you see concussions? If you could comment on that in brief.
Yeah, no, concussions, thankfully, well, I don't know, thankfully or not, headaches are always the bane of our existence in internal medicine, sometimes in clinic. Thankfully, concussions are dealt with strictly by the sports medicine doc on the team. So they have very strict protocols. The only time that I saw concussions and did some brief assessments was my one on-field game when they needed an extra physician on site. And there's a few players that had some significant head trauma where they were quite rattled, but beyond that, I don't deal with them afterwards. Or I don't see them afterwards, so I shouldn't say deal with them.
Yeah, quite a team of physicians with all kinds of different areas of specialty required, to be on the roster between sports medicine and, as you said, orthopedics and internal medicine. They're so fortunate to have you there helping out with all of these tricky conundra. So that looks like brings us to the end of any questions, Jason. And I'd just like to thank you again for putting together a really engaging talk and really interesting discussion following the talk. And I'll wish everybody an excellent rest of their day, and we'll see you back next Thursday. Take care.
Thanks so much.